Hello and welcome, everyone. I think we are ready to begin. But firstly, I'd just like to ensure that everyone can hear me. So if you can you please type yes into the chat box, which you'll find on the left-hand side of your screen? Perfect. Thank you so much. All right, that's perfect. You can all hear me. So welcome to Asthma Canada's Asthma and Nasal Polyps webinar with Dr. Shaun Kilty. This webinar has been made possible through an educational grant from Sanofi Genzyme. I know many of you have been looking forward to this presentation, so thank you so much for joining us. My name is Kristen Bawa, and I'm the Manager of Communications at Asthma Canada, and I'll be your host today. So before we begin, I'll just go over a couple quick points. This webinar is being recorded and will be uploaded to our website shortly, so absolutely you'll have access to it afterwards, and please do feel free to share within your networks once we make the recording public. All attendees are muted, but at any point if you have questions, comments, concerns, please type into the chat box. I'll be monitoring that throughout. There's also a little blue question mark at the top of your screen. You can also type your questions there. There will be a Q&A at the end, and thank you to all who submitted their questions in advance. But absolutely, if something comes to mind, type it in as we move through the presentation. So, there we go. So very quickly, I'd like to highlight some of our work. Asthma Canada is the only national organization solely dedicated to helping all Canadians affected by asthma. At the heart of all we do is our vision to empower every child and adult in Canada with asthma to live an active and symptom-free life. We're committed to improving the lives of the Canadian asthma community through education and support services, advocacy, and research. Asthma Canada encourages self-management by helping our community take control of their symptoms. We do this through our educational resources and services like our asthma and allergy helpline and webinar series, just like this one. We're also committed to bringing your voice to the forefront of policy decisions that affect our community, advocating on important issues like sustainable clean air and energy, choice and access to treatments, and access to medication in schools. And of course, Asthma Canada supports research into better health outcomes and the eventual cure for asthma. Our national research program supports graduate level students studying early or late onset asthma. And much of the work we do is through our community of volunteers and members across the country. People living with asthma, their families, parents, caregivers, healthcare professionals, educators, and others who are strongly committed to improving asthma care and quality of life. The Asthma Canada Member Alliance is a free membership of Canadians who engage in all the work we do, who provide support and input into our initiatives. So I absolutely welcome you to join us if you haven't already. And now I'd like to introduce our distinguished presenter, Dr. Shaun Kilty, at the top there. So Dr. Shaun Kilty is a full clinical professor and vice chair research for the Department of Otolaryngology, Head and Neck Surgery in the Faculty of Medicine at the University of Ottawa in Ottawa, Canada. Dr. Kilty provides subspecialty care for patients with diseases of the nose, paranasal sinuses, and skull base at the Ottawa Hospital. He is a senior clinician investigator in the clinical epidemiology program at the Ottawa Hospital Research Institute and holds several Canadian Institutes of Health Research grants. His research interests are in clinical trials and treatment strategies for sinonasal and skull-based diseases. So thank you, Dr. Kilty. It's a pleasure to have you with us today. I'm very happy to pass the presentation over to you.
Great. Thank you so much for the kind introduction, Kristen. Thanks to everyone for joining. I hope you find this informative. There we go. I've got control. So, as you know, we're going to talk about nasal polyps and asthma, and I hope that this is a bit of an education, or it provides a little bit of insight for you about chronic sinusitis with polyps and how it's managed, and some of the issues that you may already be aware of if you are a patient with that disease, or if you're not, what patients with chronic sinusitis with polyps are typically going through. So these are some of my disclosures there. The objectives I think you've already received, so we don't need to belabor that point, and we'll have plenty of time at the end actually for questions. So the first question that comes to mind is some patients ask me, what is chronic sinusitis with polyps? So if someone's diagnosed with that, they know what the symptoms are because they're experiencing them, but they really don't know what it is. They may have never heard of it before. A rudimentary definition is that it's just inflammation. So, like swelling, just like people would get an arthritis, you get inflammation in the affected joint, you get swelling in the affected joint. Well, chronic sinusitis, it's inflammation, but it affects both the nose as well as the sinuses. And that's why you have symptoms when you're breathing through your nose or when you're trying to smell. And also why you have facial pain sometimes with this disease, because it's affecting the sinuses as well as the nose. And in Canada, we need symptoms to be present for at least 8 consecutive weeks. And that's usually not a problem to make the diagnosis in our healthcare system because of some of the delays that patients have in accessing care, etc. So it's fairly easy actually for us to make that diagnosis. We rarely see someone where we're waiting for that 8-week time mark to expire before we can make that diagnosis. Now, some of the symptoms that patients will have, and these vary amongst each patient, both whether they have the symptom or not, or how intense that symptom may be for them. But these are what we call the major symptoms of chronic sinusitis. So we're looking for these in particular when we're screening patients. So nasal congestion or fullness. So kind of if you have allergies, you get a lot of nasal congestion. So I personally find nasal congestion a difficult one to describe or for patient to describe to patients, but they seem to be able to relatively easily be able to relate to that. Facial pain or pressure, that can be either in the cheeks or the forehead. Those are the typical locations for pain related to chronic sinus disease, although there's some other locations where patients may experience pain for specific types of chronic sinusitis. Nasal obstruction, so just difficulty breathing through your nose, both in and out, moving air through the nose, is a fairly common symptom, especially in patients who have nasal polyps. So discharge from the nose is another fairly common symptom. It's a common symptom for many other nasal diseases as well, like allergic rhinitis or any type of rhinitis. Most patients with a rhinitis end up having some kind of runny nose. In chronic sinusitis, we're looking for purulent or usually colored secretions, which are fairly typical of chronic sinus disease. Occasionally, there'll be clear secretions that are fairly abundant. And then one of the big symptoms that really probably drives patients in to see us, aside from the nasal obstruction, is the hyposmia, or what we call anosmia. So decrease in your sense of smell or a complete loss of the sense of smell. And that's a fairly common symptom in patients with chronic sinus disease, both with polyps and without polyps. Now, what is the real problem with chronic sinusitis is that it affects a large proportion of the population. And I think more people would be aware of the disease if, for instance, your skin turned purple when you had it. But with chronic sinusitis, no one can see that you have the disease. If you work with someone who has chronic sinusitis, a lot of the times you might just think that person has a cold very frequently throughout the year. And it's more than just having a cold, though, having chronic sinus disease, and it affects a not insignificant proportion of the population. And it is associated with significant what we call morbidity, so a decrease in your overall quality of life, and that's related to the chronic sinusitis. And there are many ways in which the impact of a disease can be determined in research. And when we look at chronic sinusitis, the impact of chronic sinus disease on patients seems to be equivalent to those who have moderate asthma. So that's usually asthma that's fairly difficult to control, as well as patients who have renal failure on dialysis. So those are both other diseases that are fairly significant and impact patients' quality of life in a negative way. And chronic sinusitis seems to have a similar impact. A large proportion of patients with chronic sinusitis also have asthma. So this is an added burden or an added impact on their quality of life outside of just the chronic sinusitis. And the cost of care for patients with chronic sinus disease is real. We did a study several years ago now, but using US data, because they have databases that are fairly robust and readily available, on every 4-year basis. And when we did this study, we looked at the costs of actually managing the disease. And direct costs are costs that are to the system. And per individual in the US at the time of the study, which the data for this is several years old now, so it would be higher, but nonetheless, it provided an estimate of close to $6,000 per patient with chronic sinusitis per year. So in 2011, when we did the study, that's when the data was from, that equated to almost 65 billion US dollars per year just to treat chronic sinus disease. And that accounted for almost 5% of the US healthcare budget, or the expenditures in the US healthcare budget. So although it's an under-recognized disease, it certainly is a fairly costly disease that has a very significant patient impact. In Canada, we can extrapolate some of those numbers. Obviously, we have a lower population with a very similar prevalence of disease. So that equates to about $870 million per year when that study was done. And the lost productivity. So productivity is not just work, patients losing income from days off work or not being able to do their job as well as they could if they didn't have chronic sinusitis. This also includes things like missing your leisure activities, all aspects of your life that actually feed into your productivity. And the cost to an individual is about $10,000 per year. So it's not an insignificant disease with an insignificant impact on people. It's quite significant. In general, we talk about chronic sinusitis in two types. And the two types we talk about are the two types of chronic sinusitis that we can classify clinically when we see someone. So we classify them rudimentarily into chronic sinusitis with polyps. So we'll see a larger picture of this later. The chronic sinusitis with polyps is largely characterized by two major symptoms, and that's patients complain of they can't breathe through their nose very well, so nasal obstruction, and then decrease in their sense of smell or loss of sense of smell altogether. They have less problems with facial pain, fewer problems with purulent discharge or kind of pussy discharge from the nose. In contrast, patients with chronic sinusitis, which we call without polyps, this disease is more characterized by chronic facial pain, so either in the forehead, the midface, or both. And that's on a fairly regular basis. So you're talking almost every day they're having these symptoms. They'll have rhinorrhea or mucopurulent discharge, so pussy type of discharge from the nose, either spontaneously or when they blow all the time. And they may still also complain of some difficulty breathing through the nose as a result of the resultant inflammation that's present not only in the sinuses but in the nose. And this is just a closer look at chronic sinusitis with polyps. So we're looking with an endoscope in the nose, which is like a fancy telescope. And what we're looking at are the big gelatinous structures in the middle. And those are polyps. Now, polyps look different in almost everyone, but in general, they kind of look like grapes that don't have the skin on them any longer. That's essentially what a polyp looks like. We somehow missed it. And the patients without polyps, so CRS without polyps, typically when we look endoscopically, now this is someone who's had surgery, but this is what we see is pus typically in some of the paranasal sinuses. And what does a polyp look like? Here, there's a polyp that was removed from someone's nose and just measured out there with a ruler for your own interest. But all it is a swelling of the lining of the nose or the sinuses. And the lining of the sinuses is called mucosa. So it's just a swelling of the mucosa, and it's full of inflammatory mediators that your body's releasing as part of its immune response. And when you look at it, as I said, it just it resembles a grape without its skin. Also in chronic sinusitis, so normally, just like on our skin, we normally have bacteria that are living there. That's just part of our normal makeup, as well as in our gut. In our sinuses, we also have what we call a normal flora, or a normal type, or various types of bacteria that normally live in our nose and sinuses. In chronic sinusitis, the type of bacteria, the variety of bacteria that live there is greatly different than in patients who are people who do not have chronic sinusitis. So there are many types of bacteria living on the lining or the surfaces of the sinuses in chronic sinusitis. So it's a real alteration from the normal. And it's not clear, though, however, at this point, if the bacteria are causative of the inflammation that is present in patients with chronic sinus disease, or do they just come in at some point? Because inflammation is a very nice environment for bacteria. It sets up a nice milieu or an area where bacteria can live fairly happily and find some of the supportive structures and elements that bacteria enjoy in order to propagate and to survive. So we're not quite sure because we don't know what actually causes chronic sinusitis at this point. So we call it an idiopathic disease because we haven't discovered why patients develop that disease to start with. And it leaves us with the age-old question of what came first. Are the bacteria truly implicated in the disease, or are they actually just there along for the ride and just make managing the disease more difficult? And there's certainly a number of impacts on the lining of the nose and the sinuses that result in inflammation or the swelling, and then eventually the disease itself. So people can have immune deficiencies. So there can be parts of the immune system that don't work well, which directly impact the lining of the nose and sinuses, which will lead to a change in what we call the innate immunity, or the immunity or the immune system, which is located within the lining of the nose and sinuses. So every structure in your body has its own little immune system there, and the sinuses are no different. And there's a number of things that can occur that impact the innate immunity or the local immune system of the nose and sinuses, which can lead then to the inflammation of chronic disease. So a systemic problem with the immune system will certainly impact the local immune system in the nose and sinuses. There are sometimes anatomic factors, although not very common. There are sometimes anatomic factors which can lead to this problem with immunity, inflammation, chronic sinus disease. Allergy can impact the local immunity. Obviously, I just mentioned bacteria and fungi. And then biofilms are the form in which bacteria live normally. So biofilm is like a coral reef. So you may have seen images of coral reefs, people swimming and diving near them. So a biofilm is essentially a coral reef, and within the reef is hiding the bacteria. And when the bacteria are there, they assume a form which is not very active, so it requires less nutrients to survive, and they can live in that form for quite a long time. And then when stimulated, the bacteria will come out and cause the kind of free bacteria, free floating bacteria, which we associate with pus and acute infections. And then when it goes back to sleep, or this so-called senescent state, they go back into this biofilm. They're living happily in this coral reef. And unfortunately, antibiotics don't have much impact on biofilm disease. So the normal state of bacteria, but antibiotics are very good at wiping out bacteria which are free floating. And then the antibiotic can actually interrupt the bacteria in various ways. However, the biofilms are not very easily or eradicated with typical antibiotic therapies, and they need some type of other therapy in order to get rid of the biofilm. Staph aureus is one of the most common bacteria which are present in chronic sinusitis, and it can release something called a superantigen. So a chemical essentially that can impact the immunity of the sinuses and the nose, and then lead to further inflammation. And lastly, mucociliary dysfunction. So the lining of your nose and sinuses have a number of tiny little hairs that emanate from them. That emanate from them, and um, the they have a normal beat that they undergo. So they actually have a beat that at a certain frequency um, that they undergo on a regular basis. And there's a number of things, both medications as well as things that float around the air, for instance, smoke, tobacco smoke. Those will impair the movement of the cilia in their normal beat, which will then impact the normal movement of secretions from the nose and sinuses to the back of your nose, eventually to your throat. And when they don't move, that ends up causing a nice environment for bacteria to come in and cause infection, as well as other problems due to the lack of movement of those secretions. So all of these things together or in isolation could impact the immune system within your nose and sinuses, lead to inflammation, and then potentially to chronic sinus disease. And there are a number of hypotheses why people get chronic sinusitis, and none of them on their own seems to be correct. So the reason for why people get sinusitis is not completely understood, as I've alluded to already. But in the future, I suspect as further understanding comes forward about the inflammation and treatments come along because of that understanding, I think we'll get a better understanding of what actually is the inciting event to cause this inflammation in the first place. And then we'll identify the factors which perpetuate or continue to cause the inflammation over the long term, even despite many different types of therapies that we employ. Well, what's it like to be a patient with chronic sinusitis? And certainly, if you ask 100 different patients who have chronic sinusitis with polyps, about their journey, you'll probably get 100 different answers. But we can make some generalizations, and there's actually some reports in the literature that include comments and surveillance of patients who have chronic sinus disease to see what their actual journey is. And we can, generalize a patient's journey in that they start at some point having symptoms of the disease. We don't know who these patients will be in advance. We're not sure exactly which inciting events may occur to move them into a symptomatic stage, but something happens. And usually it's somewhere between the age of 20 and 40 that most patients will begin to have symptoms, although there can be patients who start with symptoms later than that or earlier than that time frame. So patients will start to have symptoms, be it runny nose, persistent stuffiness or congestion, postnasal drip, facial pain, loss of smell, or decrease in your sense of smell. And at some point, you develop symptoms, and then this will lead in our healthcare system usually to a GP visit at some point. And then from there, patients may be referred or flow either to an allergy specialist, potentially to an otolaryngologist or ENT, maybe even a respirologist, depending on which symptoms they present to their GP with. And from there, there may be some interplay among specialists. They may see an allergy specialist. They may be diagnosed with allergies. Maybe they go on a treatment for allergies, but they haven't been diagnosed with the chronic sinusitis, which they have, and they remain symptomatic. Maybe eventually they get to an otolaryngologist. There are many pathways that patients may take through this algorithm before arriving at an ENT and before arriving at the actual correct diagnosis of chronic sinusitis. And certainly this can be weeks, but probably most likely in the Canadian healthcare system, you're looking at months to years from the onset of symptoms before patients reach a diagnosis. And then once they reach a diagnosis, obviously there are some treatments that become available. And unfortunately, as a chronic disease, chronic sinusitis, we're looking at managing symptoms because we don't have a curative treatment, although there are many patients who may have quite dramatic responses to treatments, surgical, medical, or otherwise. Usually they still have the disease and the disease is still there. They're just not very symptomatic of it. And then this leads to a frequent, kind of flow of treatment and reassessment and treatment and reassessment. And maybe the treatment doesn't change if the symptoms are stable. But if the symptoms are continuously changing, this may lead to frequent changes in the treatment regime or regimen and frequent reassessment. So obviously, there's a lot of contacts with the healthcare system for patients with chronic sinus disease. As I was saying, most patients, usually the onset's between 20 to 40 years of age. In Canada, we seem to see more at the specialist level anyway, chronic sinusitis with polyps than patients without polyps. Um, Symptoms of disease often can mimic other diseases, as I alluded to, allergic rhinitis being much more frequent or prevalent disease in Canada, especially where I am in Ottawa. Allergic rhinitis is almost endemic. Um, Patients will often be diagnosed with allergic rhinitis, and maybe they get started on a therapy for that, but their symptoms progress. So it may take additional time then before the correct diagnosis is made. And there may be a lot of misdiagnosis because of crossover between different nasal diseases, delay in treatment, delays in referral, and then sometimes it could be just lead to disease mismanagement. So there's a whole lot of factors involved. And as I alluded to, for specialist care in Canada, it's usually dependent on contact with a primary care provider. But there are difficulties in our environment now that maybe weren't as prevalent several years ago. So access to primary care is a real burden. There are many people who don't have a primary care provider, so they don't have a general practitioner that they can go see. So once you become symptomatic, who are you supposed to see? Unless you go to a walk-in clinic, you may not be able to see anyone. Issues with recognition of the disease and the first presentation potentially with the primary care provider. Maybe the symptoms aren't that significant at that time, difficult to even consider chronic sinusitis, or maybe they're just initiated some kind of therapy and then the primary care practitioner holds on to that patient for quite a long time, trying things like topical steroid sprays, etc. and despite trial and error, maybe there's not success, and these things all occur prior to referral or diagnosis of the chronic sinusitis. It could be prolonged medical therapy that's unnecessary or ineffective. And certainly, if your general practitioner goes and orders a CT scan, in many areas, it could be 2 years before you get a CT scan of your sinuses. So this is an obvious cause of delay, given CT scan is one of the ways in which chronic sinusitis and chronic sinusitis with polyps is actually diagnosed. There may be, in some cases, potentially conflict between the patient and their healthcare provider, which doesn't fuel referral nor effective maybe management of the patient's problem. Lack of primary care provider or access to care, not just within big cities who just don't have enough primary care practitioners, but in other areas of the country where there's just insufficient numbers of primary care providers and fairly large populations, or patients who live in remote areas who just don't have access to care. And then lastly, referral to, we'll say, the wrong specialist, but maybe not the most appropriate specialist at the time, depending on what your symptomatology is. So if you have chronic sinusitis without polyps and you have a lot of headache or facial pain, maybe you get referred to a neurologist. The wait to see a neurologist can be extremely long. And then they decide that you don't have headache, but maybe they do an MRI at the time, because they often do MRIs for headache and find that you have chronic sinus disease, which leads to yet another referral. So there are a number of reasons why the diagnosis may be delayed, and once the diagnosis is made, there may be some delay in attaining treatment. Otolaryngologists, or ENTs, as we're commonly known, are probably the most appropriate group to see for chronic sinus disease and chronic sinusitis with polyps. We're the only group who can provide all of the treatments required for patients. So one of the treatments is surgery, although it's not the only treatment. But aside from the medical therapy, once that's failed, then we're usually looking at surgical treatment, and the ENTs would be the specialist group who would provide that kind of care. Well, what do patients think? Well, there was a study published not too long ago out of the UK, and a lot of similarities when I reviewed this paper, a lot of similarities to what patients will tell me or what I've experienced in clinical care. So a similar healthcare system in the UK as to Canada. And some of the experiences of patients there, I'm sure, are not much different than patients here in Canada. So they interviewed 25 patients with chronic sinusitis to try and ascertain, their views and experiences in the kind of primary, secondary care. So they have a similar system where you see a primary care specialist and then are referred on to a specialist. So some of the same frustrations and issues will come up there as come up here. And one of the summary quotes was that participants often describe frustration about not being listened to by their GPs, or the GPs being dismissive or disinterested in their symptoms of CRS, and not understanding the full impact of CRS on a patient's or a participant's life. I think that's probably a fairly good generalization for most of the population. If you told them about your symptoms, they'd probably say you have a cold. And most people don't recognize or know about chronic sinusitis, or recognize that there is a chronic disease there that can affect your nose and sinuses on a long-term basis. Participants often reported difficulties in seeing the same GP at subsequent visits. So maybe you develop a good rapport with one, but you're in one of these practices where you may see any particular GP on a scheduled visit. And maybe there's some aspects of care that get lost in translation. Because along with your symptoms come interpretation, and someone might interpret your symptoms different than someone else, and that could lead to a lack of continuity of care, and that could delay both treatment and referral onward. And one patient who was 22 with chronic sinusitis with polyps was quoted as saying, "It was a long process because you keep going back to the GP over a period of months and months, probably a year or so, to finally make them realize essentially what you have before you get referred on." So it's probably not an uncommon problem. And even delays for treatment can occur once they've been assessed by a specialist. A patient with chronic sinusitis without polyps quoted as saying, "Yes, surgery obviously is always looked at as a final thing. So often we use medical therapies first and then only embark on surgery when medication is not providing significant symptomatic relief." In which the patient says, I disagree with, because it was the best and only thing for me If they had done that 11 months earlier, speaking to treatment delays and delays to access to the operating room, I think it would have made everyone's life a lot easier. So CRS with asthma. So chronic sinusitis, as I alluded to earlier, occurs in about 50% of cases with concurrent asthma. And asthma will often make the inflammation of chronic sinusitis worse, or patients with asthma and chronic sinusitis just have a higher burden of inflammation or worse inflammation, which means that it becomes more difficult to control their symptoms of chronic sinusitis. And also, it makes it more difficult to provide them a satisfactory long term outcome with surgical therapy. And if we look at three different severities of chronic sinusitis with polyps on this slide, we see that patients who have just isolated chronic sinusitis with polyps will undergo surgery. If we look at the 5-year mark following surgery, about 40% of those patients will have recurrent of disease and or need surgery again at that point. But if we start adding on other types of inflammation or other reasons for having more severe inflammation, such as asthma, you see that that number goes up another 20%. So 60% at 5 years will have recurrence of their polyps and or need surgery. And if we add yet one more level of inflammation to the patients who have asthma, chronic sinusitis with polyps, and then what we call NSAID allergy or sensitivity, so sensitivity to aspirin, ibuprofen, Advil, those sorts of things, they tend to have a much more severe inflammation that affects their nose and sinuses as well. And once you hit the 5-year mark for those patients, you can see that 90% will have polyps that have returned and or need surgery again. So as the severity of the inflammation increases, there's greater difficulty in controlling the inflammation and then providing patients with satisfactory symptom relief over the long term. And there is a similar inflammation which is present in patients with asthma as well as patients with chronic sinusitis with polyps. And we're not going to get into the specifics of different types of inflammation, but they call it essentially type 2 inflammation, which is the most common in chronic sinusitis with polyps. So there's type 1, 2, and 3. Most patients with polyps will have type 2 inflammation, which kind of predominates in their disease, although they may have some of the other types of inflammation that are present. In patients with asthma, by and large, when you have polyps, will have a very similar inflammatory profile going on in the lungs. So these aren't isolated diseases, they're more believed to be systemic inflammation affecting both the lungs and the nose. And when you look in the blood for markers of this type of inflammation, they can often be found. So it means that some of these markers of inflammation are circulating throughout the body. So it's not just isolated disease in the nose and sinuses and the lungs, but these diseases predominate in those areas. Um, Other diseases that have type 2 inflammation, so allergic rhinitis. Now, you can have chronic sinusitis and not have allergic rhinitis, although a large proportion of patients, about 70, sometimes 90% of patients with chronic sinusitis with polyps will also have allergic rhinitis. So, an added burden to their symptomatology. There we go. Oh, slide almost didn't come there. And obviously, the burden to patients increases when you have both asthma and chronic sinusitis with polyps. And it's been well shown to have that these patients, if you compare them to patients who have CRS with polyps and not asthma, that these patients with asthma will have a poor health-related quality of life. So they just have more inflammation, harder to breathe. So their quality of life is lower. They have greater use of systemic steroids, so things like oral prednisone that are used in bursts, both because they have asthma and chronic sinusitis. They may be getting treated concurrently or independently using oral steroids for both the diseases or either one, so that you may have more steroid exposure and therefore greater risk of adverse events or complications from using steroid. And then the increased recurrence of polyps following surgery is much higher, as the previous slides alluded to due to the higher burden of inflammation. So the disease is just, we could say, more severe in a certain way. Well, what are the options for managing patients with chronic sinusitis in Canada? They're probably not much different around the world, honestly, at this point. But how do we tend to approach patients? In general, in Canada, we really, similar to UK and other countries, we really look at maximizing medical therapy first, because although surgery can be effective, there are certain risks with surgery. And if you can avoid those risks of surgery, then why proceed with surgery if you can get satisfactory symptom control? Surgery is always there as an option, but we like to exhaust the medical therapies first prior to proceeding with any type of surgery. So the long-term goals really of managing chronic sinusitis are really to improve in patients with nasal polyps, improve their ability to breathe through their nose. Sometimes we can improve their sense of smell at the same time. That one's a difficult symptom to improve. And control their infectious complications or complications of disease. We're trying to overall reduce the burden of the nasal symptoms and loss of smell, reduce the size of nasal polyps, and reduce their use of systemic steroids, so prednisone that you take by mouth, just because of the risks associated with use of prednisone and chronic use of prednisone. And if you use prednisone frequently enough throughout the year, it's like some of the risks become the equivalent to taking the prednisone every day. This slide just reiterates kind of the approach to chronic sinusitis. So, going through medications prior to considering surgery. And patients who have chronic sinusitis with polyps, in particular, may be subjected or have any or a combination of these medications used at some point. So, the most common medication that any patient with chronic sinusitis will use is a topical intranasal corticosteroid spray. So, these are sprays which are quite weak. They have very little systemic absorption. So it's not like taking the oral steroid pills where there's a large amount of systemic absorption and a large range of potential systemic side effects. The intranasal corticosteroid sprays are in general quite safe, most common side effect being nosebleed. And the nosebleed usually occurs because the sprayer or the applicator itself is not aimed in the correct direction and spraying on the patient's nasal septum, which will eventually lead to dryness and then some nosebleeds. But this is a medication that has to be used daily because it's not extremely strong, and because the way the nose works and moves the therapy or the spray right out of the nose eventually before or after the medication degrades. So it's a daily type treatment that needs to be used. Oral corticosteroids, as I alluded to earlier, these are taken on an everyday basis, but we tend to use them for chronic sinusitis with polyps in very short bursts, so 7 to 14 days. We tend not to go beyond 14 days because then you need to be weaned off the medication. And we tend not to use it chronically, so on an everyday basis for months on end because of the systemic effects of the oral corticosteroids. Some of those effects could be worse than your chronic sinusitis, so we have a tendency not to use them in the long term. Antibiotics can be used in chronic sinusitis with polyps. Usually we use them only if we're seeing pus in the nose. If we don't see any signs of pus, we don't find a high value of using an antibiotic. And then if we don't use it, then that decreases any of the potential side effect risks of using antibiotics. And there's a great amount of scrutiny that's come out over the last decade over antibiotic prescription and antibiotic use. And there's probably more judicious use of antibiotics now than there has been in the past. Low-dose macrolides are a type of antibiotic that can be used, but when you use them in low dose, actually, you're not killing bacteria with those doses. There is a profile of this medication that has anti-inflammatory properties, and in some patients, they can be effective. These tend to be used over several month period because you're looking at the anti-inflammatory effect of the medication. They're certainly used in other patient groups, such as patients with cystic fibrosis, to use the anti-inflammatory property of the medication over the long term to better control inflammation and decrease symptoms. There's another class of medications which are sometimes used called leukotriene receptor antagonists. They're used sometimes in patients with both asthma and chronic sinusitis with polyps, or patients with the Samter's triad, as that should be the group that patients respond the best, although I find these medications overly disappointing, unfortunately, for a majority of patients. And then aspirin desensitization is another therapy that's available in some centers, usually done by an allergist, where patients with the AERD or Samter's triad, so this would be the only group this would be used for, are actually desensitized. So an allergist would desensitize them, meaning they end up taking, by desensitizing them, they end up staying on aspirin on a daily basis. So the medication that used to cause them symptoms doesn't cause them symptoms because their body's been desensitized to the the effect of the NSAID, but they have to stay on this therapy on a daily basis to maintain that benefit. And this can be problematic in patients who have to stop aspirin in order to go for surgery for any reason or any other kind of medical event in their life. And if they stop the therapy, then they have to usually be desensitized again. Just quickly speaking to the benefits of steroids that we take by mouth, they can be effective, but for most symptoms that we look at, either the size of the polyps, the loss of sense of smell, some of the other symptoms of chronic sinus disease, they have a very transient effect. So they're given over 7 to 14 days usually, but most of their benefit is usually lost by 3 months. So if we administer oral steroids to someone, we'll usually check back with them at the 2 to 3 month mark, because we know that if by then, if the effect is going to be lost, we would see it at that point. And if it's the symptoms are still in check at that point, then they may get a long-term benefit with just continuing on with their daily topical steroids after systemic therapies been completed. Endoscopic sinus surgery. So, as I alluded to, this is done for patients who have essentially what we call failed medical therapy. So, we've tried medical therapy and it's not provided satisfactory uh, symptom response or a long term symptom control. In general, this is done with patients asleep in the operating room. In general, it's a day surgery. Why it's done is to improve sinus drainage. So we widen the outflow tracts of the sinuses. It allows air into the sinuses. So air is a natural antibiotic. So it seems to be helpful to control some of the inflammation of the sinuses related to bacteria presence. Allows for topical application of medical therapy. So in some patients, we may use a rinse where we deliver not just salt water, but salt water with a topical steroid. And then that allows the steroid to literally get into the sinuses that have been operated, which the steroid wouldn't do prior to having any surgery. So the sinuses, the openings for the drainage pathways for the sinuses are only a few millimeters in size. After they've had surgery, they're much larger than that, and it actually permits the entry of some of the topical therapies. Loss of smell and taste is one of the most frustrating symptoms for patients and frustrating for physicians as well, because it's a difficult symptom to improve. Even if all your polyps are removed, your sense of smell may not return. And that can be because there's inflammation that's still present in the smell receptor area of the nose, which is usually an area that doesn't necessarily have polyps. But if there's inflammation present, the inflammation itself can interfere with the messaging system or the nerve system, because every odor lands in your nose has to bind to little nerve receptors, and then that sends a signal to your brain, and the combination of signals that's received really tells your brain what you're smelling. And the inflammation that can be present can interfere with that binding of odors, and then you're not getting any transmission. So the nose may not have any polyps, the air may be flowing through the nose, but nonetheless, sense of smell may not be restored. But in a large proportion of patients, we can certainly improve the sense of smell to some degree, although complete improvement can be difficult with surgery. So one of the newest therapies that have come about in the last year, roughly, for chronic sinusitis. Now, these have been present for other diseases such as asthma, but monoclonal antibody therapy. So we're not going to go through this diagram, or as one of my colleagues likes to call it, the confusogram. Uh, but essentially, there are targeted therapies. So these are therapies that are injected subcutaneously. So like an insulin injection is subcutaneous, these are usually injected subcutaneously at different time periods, maybe once a month or once every 2 weeks, depending on the exact monoclonal antibody. But what they do is they block an aspect of the inflammation pathway. And by blocking that inflammation, it decreases the inflammation that's present in the nose and sinuses, which improves your symptoms and then provides overall better disease control. The issue with the monoclonal antibody therapy is one is access. So most people need to have some kind of private insurance to afford it, because it's usually several $1,000s per month if you were paying out of pocket. And most people I know, including myself, wouldn't be able to pay a few $1,000s a month out of their pocket to access these therapies. So usually at this point, need private coverage if the indication is for chronic sinusitis with polyps. This is an evolving story. So right now there are two therapies which are available. There may be more shortly that are Health Canada approved, and then there are more that may be coming in the future. So this is the one area that we'll probably see a lot of movement over the next 5 to 10 years in therapies for chronic sinusitis. Is these so-called monoclonal antibody therapies, are really targeted therapies where they target one aspect of the inflammation, and by blocking that, they decrease the inflammation and improve the symptom control. But these therapies largely have to be used continuously in order to maintain that effect. So if you were on a monoclonal antibody therapy and then stopped it, usually within several months, your chronic sinus disease anyway would be back to where it was prior to you initiating therapy. So this is a very interesting area, but at the same time, it's holding a lot of promise, and we'll have to see where this goes over the next few years. So in summary, chronic sinusitis is a fairly common disease of unknown etiology. So it's what we call idiopathic. It comes with very significant symptomatology. It can start as early as the third decade, but it could start literally at any time. Medical therapy is often used to manage chronic sinusitis with polyps. We use it both preoperatively and postoperatively. So we'll use it before people have sinus surgery, and we'll usually continue some type of medical therapy afterwards, usually a topical steroid, because that's what helps control the inflammation over the long term. And then monoclonal antibodies certainly may offer some hope in the future, and it will be an interesting area to watch as it evolves.
Thanks so much, Dr. Kilty. I know that was incredibly informative for our community. We'd really appreciate it. I do have quite a few questions that have come out, so I will just get right to them. Um, our first is from Bash, who is on the call today, actually. So Bash asks, my nasal polyps has led to loss of smell, but my sense of taste is fine. The nasal polyps in my friend has led to loss of both senses. Is this due to where the polyps are, or size of polyps, or perhaps something else? Thank you.
That's a good question. So usually taste is limited to sweet, sour, bitter, and umami. Those are the tastes that we have, and then all of the aromas that come with food really come from your sense of smell. So when you chew, so if you put something in your mouth and it's salty, you'll taste the salt right away. As you chew, the aromas that come out of the food as you chew actually make their way to the back of your mouth. They go up through the back of your mouth and in through the back of the nose and arrive at your smell receptors. And that's what gives you all the flavors of food. So without the sense of smell, food is limited to sweet, salty, and sour, and those sorts of things. But it's the sense of smell which really provides the aromas of food and all the flavor that we appreciate in food.
Nice. Bash has another question as well, but I will get to that in just one moment. This question comes from Heather, who asks, do you feel that my colon polyps could be related to my nasal polyps? I've always had asthma and nasal polyps, and they've been surgically removed about every 10 years of my life. I'm 55 now.
That's a good question. A number of people have asked me this. It doesn't appear that polyps that occur in your colon have any relationship to polyps in the nose. So the polyps in the colon seem to come about through a different mechanism or a different reason why they come about than polyps in the nose. So the two don't appear to have any relationship at this time that we know of.
Okay, this next question is from Carol, who asks, how can I shrink nasal polyps without drugs or surgery? Um,
That's a very good question. I don't know is the honest answer. I have some patients who say in the environment I'm in, where there's a lot of allergens in the air. There's some patients when they leave a very humid living environment and go somewhere very dry, where they say they have an improvement. Obviously, I don't get to travel with them and scope them and see if their polyps reduce. That'd be a good study. But without medication and without surgery, I'm not sure of any ways to naturally reduce them. Some patients like rinsing with salt water, but that in itself yet hasn't been shown to reduce polyps or reduce the inflammation. Rinsing with salt water will remove some of the inflammatory mediators that are present in the nose and rinse out some secretions. But overall, the inflammation of polyps it's just a slowly progressive disease where the inflammation just continues slowly, and for patients with polyps, the polyps just slowly continue to increase in size.
Okay, that's fair. This is a great question that comes from John, who asks, following surgical removal of a nasal polyp, post-surgical checkups should continue for how many years?
Well, that's a good question. Everyone has a slightly different practice pattern, and depending on the patient and the severity of their inflammation, that'll also help structure some of the follow-up. So someone with, the NSAID sensitivity, asthma, chronic sinusitis with polyps, they're usually followed, depending on their disease control, at least annually, just because the burden of disease is so high. There's usually a lot of therapy modifications that have to be made over time. Someone who's had surgery for their nasal polyps, and maybe they've been followed for a year or two, and there's no sign whatsoever of polyps coming back, and they're just using their topical therapy. They may be fine just to be referred back from their general practitioner if again they start to develop symptoms that don't respond to their normal therapy over time. So I think it needs to be an individualized approach. I don't think there's a set structure for every patient, and it's usually related just to the severity of their inflammation and the ability to gain symptom control with the available therapies.
Okay, so this is sort of a follow-up from Bash as well, which he asks, is there a maximum number of polypectomy procedures one can take over the years? They share, I've already had 3 and need a 4th one, but the ENT doctor doesn't think they should do it. Yeah, what are your thoughts?
Yeah, I haven't seen that there is a limit, and I have had patients who have approached me and have avoided seeing an ENT for several years. One was a patient in her late 70s who came to me finally because her nose was full of polyps, but she was told like a couple of decades prior that she had had 3 surgeries and that was it. But there doesn't seem to be a limit, and certainly she was very happy to undergo her 4th surgery because that provided a lot of improvement in her quality of life. So I don't know that there's a definite limit on numbers. Certainly, patients who present in their 20s, unless there's a huge breakthrough in chronic sinusitis and the real cause of the disease is identified, they can probably anticipate that they're going to end up having several surgeries throughout their lifetime just to remove the polyps because in some patients, despite good medical care, the polyps, the amount of inflammation that's present will just overwhelm the topical therapies that they use, and the polyps will come back. And once they're of a certain size where it's not responding any longer to medical therapy, then oftentimes the only thing left to do is to remove the polyps again surgically.
Okay. Um, there's 2 questions next that come from Sylvia, who's on the call today. And Sylvia asks, can you demonstrate or show correct nasal steroid technique? And also, are you able to review the effectiveness of when and how often to do nasal irrigation? And maybe touch on neti pot versus using bottle irrigation.
Yeah, so I'm just looking to see if I have a pen here to use to point at my nose, but I don't see it. But essentially, the way to apply the nasal steroid spray, so the nasal septum, or the structure I mentioned in the presentation, is sitting in the middle of the nose, on the inside of the nose. So if you put the bottle in and aim this way towards the middle of your nose, the spray is going to land on the nasal septum. Eventually, it's going to cause drying of the nasal septum, and then you'll get nosebleeds. The correct way is to angle the spray. So you put it in the nose, you angle upwards and backwards. You're kind of aiming towards the inside corner of your eye. That's kind of the direction you're aiming in, and you're aiming in that direction because the sinuses are situated in that general vicinity. So if you put the spray in, you aim to the side and a little bit upwards towards the inside corner of your eye. That's generally where the spray will then land. It's less likely to cause you any nosebleeds. And Also, it'll do a better job of actually treating the sinus disease because it won't just be landing on your nasal septum and drying out the nasal septum. The other part of the question was timing.
I believe so, yeah. Reviewing the effectiveness and when and how often, and
So,
also neti pot versus bottle irrigation.
so the topical sprays in general, they are indicated for use once daily, so 2 sprays on each side once a day. Some clinicians may suggest to a patient using them up to twice a day, depending on the severity of their disease. Um, as far as comparing irrigation, so the irrigations are salt water, so using them just on their own won't benefit the inflammation, although most people symptomatically feel better for at least 5 to 10 minutes after doing an irrigation. If you're using irrigation with salt water, you should do it before you apply the nasal steroid so you're not physically rinsing out the nasal steroid. And in those patients who are having steroids applied through irrigation, so they may be prescribed to use, like the sinus rinse bottle, for instance, which is a squeeze bottle, and then sometimes a steroid is added to that, which is different than the nasal sprays. The steroid that's added to that would then circulate through the nose and sinus cavities if they've had surgery. And a lot of it will come back out of the nose, but everywhere the saline flows, it leaves a little bit of steroid behind. So then all those surfaces which are touched by the salt water essentially receive some steroid treatment. And that seems to provide a little bit better symptom control and disease control, just because more of the lining of the nose and sinuses is having the steroid reach it than with, for instance, just the nasal steroid spray.
Yeah, very helpful demonstration. Thank you. Erigen asks, how often would you prescribe a monoclonal antibody preoperatively versus postoperatively?
So at this point in time, the Canadian Society of Otolaryngology. So there's a working group of rhinologists, so people who are otolaryngologists who spend most of the time treating patients with nasal and sinus diseases. So when monoclonal antibodies first started to be approved for chronic sinusitis, which was about a year ago. We looked at the evidence and came up with our recommendations because there's not good recommendations out there in the literature on how to embark on monoclonal antibody therapy. One of the issues, obviously, is cost with monoclonal antibody therapy. Um, so the recommendations by the group was to obviously, as we're currently doing, exhaust normal medical therapies, uh, utilize surgical therapy because when you compare the cost of surgical therapy to monoclonal antibody in some of the studies done comparing costs and effectiveness, the surgery still comes out on top because it's very much less expensive to the healthcare system and the patient than the monoclonal antibodies. So after someone's tried medical therapy, had at least one good surgery, if they have polyps which still come back after that, and we then consider monoclonal antibodies an option to consider. Still, there may be patients who won't consider the monoclonal antibody for a number of reasons. It's a systemic injection, so your whole body is obviously exposed to the monoclonal antibody. They've been shown to be safe, but some people may opt not to consider it at that point. So usually at this point, we're recommending it after people have had the regular therapies for chronic sinusitis.
Okay, I know we're getting close, so I will just do maybe one more question if you're up to it, Dr. Kilty.
Mhm. No problem.
So Nick asks, as an ENT, how do you feel biologics will fit into your treatment options?
Yeah, so that's the monoclonal antibodies at this point. It's going to be a fairly evolving area. It'll probably be the area that evolves the most over the next decade, I'd say, for patients with chronic rhinosinusitis and people who treat those patients. Um, I think the targeted therapy will keep changing. So what is targeted will keep changing. So every monoclonal antibody that comes out currently it targets a different part of the inflammation. So there are trade-offs with which area of the inflammation you target, and that can lead to improvements in the efficacy or how well that therapy works compared to some of the other therapies, as well as what other effects it may have. Um, I think the biologic therapies certainly offer a lot of promise for patients with chronic sinusitis, and certainly we're seeing some of those results clinically. Um, exactly where the biologic story goes over the next decade, I can't predict at this point, but it will be interesting. As I alluded to already, one of the major issues, however, with biologic therapy is cost. Uh, the thought is always that, when therapies first come out, they cost the most, and as time goes on, the cost is reduced. We'll have to see if that happens similarly for biologic therapies over time, and to see if they become more widely applicable, because access to them is still fairly limited for patients. Even if they have private insurance, there are many insurers who may not opt to cover those therapies. So access to therapy is a significant issue for patients.
Of course. Thank you so much, Dr. Kilty. Okay, so I think we are basically at the end of our time, but again, thank you so much, Dr. Kilty, for taking the time to give us this presentation, and thank you everyone for attending. If at any point you have further questions or we didn't get your question today, please email us at info@asthma.ca, and we'll be happy to help. Yeah, I just thank you so much again. This has been wonderful. We're super grateful. Thanks.
My pleasure, and thanks for everyone for your interest.